I'm Dr. Jay Anders, and this is Tell Me Where It Hurts, where we discuss some of the big challenges in health IT and how we can solve them so clinicians can do what they do best, care for patients. I'd like to welcome everyone to another episode of Tell Me Where It Hurts. Before I introduce today's guest, who probably really doesn't need an introduction, I was talking with a friend, old colleague of mine the other day about interoperability and responsibility and all of that. And he harkened back to the days where I'm from a large multi-specialty group practice background, so we had a unified medical record. Pretty much everything about a patient's ever been done was in that medical record somewhere. Of course, it got a little bit better when it got electronic, and then we've got problems finding things and all that kind of stuff. But one of the interesting things, which we'll get into today a little bit, that we did talk about is responsibility in interoperability, meaning what am I responsible for in receiving information, what am I responsible for giving information, how much do I give, things like that. Because I remember very clearly when we were setting up our electronic health records about talking about the medication list. We had a psychiatry department who did not want to share their med lists with anyone. And I said, that's a danger. We cannot have incomplete medication lists because I'm going to prescribe something that interacts with something you prescribed, and then we're in trouble. So I understand that you want to keep everything about a psychiatric condition private, but you can't, that you can take it too far. And we finally met in the middle, and yes, they did include all of their meds. What was interesting, though, is for an internist like me, I can look at a list of meds and pretty much tell what the patient has just by looking at the medications. So they're not keeping anything secret. But we'll talk a little bit about that when we get a little bit further down in the interview. Today's guest has been here before, and I thank you for coming back. It's Micky Tripathi, who is the National Coordinator for Health Information Technology at the U.S. Department of Health and Human Services, where he leads formulation of federal health IT strategy and coordinates federal health IT policies, standards, programs, and investments. Welcome, Micky, to the program again.
Thanks so much, Jay. Glad to be here. And I've been in the job almost 2 years now, and that still sounds like the description of the job, you know. You never know.
Other duties as required.
Right.
So things have been progressing along with, this 21st Century Cures Act and information blocking, sharing rules, and things like that. They've been around, the rules have been around for a while now, but the implementation of those rules has started. So can you give us a little bit of an update on that and what people can expect?
Yeah, the 21st Century Cures Act, the interoperability pieces of it, and there's a pretty broad law that covered a lot of different things, but the pieces that relate directly to ONC and interoperability were in three categories. One was the information blocking provisions, as they were called. I like to think of them as the information sharing provisions, but they were called the information blocking provisions. The second was standards, and that's to have standard APIs to allow access to information without special effort, which is what the statute actually said. And there's also data standards that we call the USCID, the US Core Data for Interoperability. And then the third provisions were related to TEFCA, the Trusted Exchange Framework and Common Agreement, which is nationwide network interoperability. So I'm happy to just, with each of those, give you a bullet or two on where we are with those, and then happy to dive down into any of those, if that makes sense.
Oh, please.
Yeah. So with information blocking, as you noted, that the law was passed in 2016. Draft rule, I think, was in 2019. Final rule was in 2020. So that took a long time. Already. That's a number of years that passed. But and then it took a while for it to actually get implemented. It got delayed a few times, and then got delayed for the pandemic. But we came in and we put it in place. So April 5th, 2021, we made it that the applicability date, meaning all of the actors who are required to comply with the information blocking rule, which is providers. That's a very broad definition of providers, health information networks, and certified technology developers, which is EHR vendors, Epic, Cerner, Athena Health, eClinicalWorks, were all required to be in compliance as of April 5th, 2021. There was another, there was sort of a phasing in the implementation that said that starting on April 5th, the information that you were required to make available as a part of the, to be in compliance with the regulation, we said that minimally, it's just that minimum data set, the US Core Data for Interoperability, USCDI, because we know that that's what's available in electronic health record systems. And, almost all providers who have EHRs support that today. That's what is available in the patient portal, for example. A provider may or may not know that, but the patient portal actually contains the USCDI. So we said, start with that because we know that that's easy, and that's for the first 18 months. But after 18 months, we have to open up the information that you're required to make available to all available information, or as the law called it, all electronically accessible information. And that was October 6th of this year. Second, and happy to dive into that. Second is related to standards. So what the law specified was that we have a minimum data set, and we call that the USCDI, which we update every year, which is basically what I think any provider, you, psychiatrist, and orthopedic surgeon would probably all agree that, sure, if we're going to agree on, what's the minimum clinical information I'd like to get for any arbitrary patient who just shows up, right? Just shows up in the emergency department, shows up, wherever. What would I minimally like to know? That's kind of what the USCDI is. And it also, we also put into place a requirement for a standard interface across all EHR systems based on modern internet conventions. So that's the FHIR API. That's required to be available to customers, so to providers by the end of this calendar year. So just 3 weeks from now, every provider should have that available to them to be able to use for access by patients, as well as sharing information with other providers, with public health, whatever they want to do. And then the third thing is TEFCA, the Trust Exchange Framework. That's network governance. Forget about what those words, it's like federal government is terrible at branding, so Trusted Exchange Framework and Common Agreement doesn't tell you anything about what that is. It's basically network governance. And the way I like to describe that is think about, the way cell phones work. You're on AT&T, I'm on Verizon, Kevin, from our staff is on T-Mobile, let's say. Those phones talk to each other, right? In the background, there has been agreements made across those service providers to make sure that those phones talk to each other, so that none of us, has the challenge of figuring out, oh, you're on Verizon, that means I can do this, I can't do that. That's what we want nationwide networks to do. That's what TEFCA does. And we announced at the beginning of this year that here is the technical framework and the legal requirements for participating in that. And we anticipate going live with that in 2023.
So tell me a little bit about the feedback you've been getting from folks. I mean, it's coming up. We're going to fall into it here in 3 weeks.
Yeah.
So can you tell me a little bit about what kind of information the providers are giving back to you about how this is going?
Yeah. So I think it's, a very wide spectrum of perspectives, as you might imagine. We're a complicated country, we're a complicated healthcare delivery system, so there's no single voice. We're certainly hearing, and I'll lump it all together in terms of sort of the different things that we're doing, almost all the things we're doing. We've gotten a lot of feedback, both from the patient community as well as from a lot of providers about the positive aspects of the information blocking provisions, that it does create an obligation and a duty to share information. I think people are starting to recognize that that's a benefit. It certainly creates a responsibility on providers, let's say, as one of the three actors, to share information, but it also means that they have access to information that they weren't able to get before. The case that you were just describing with a psychiatrist, for example, that actually would not, under the information blocking provisions, those psychiatrists are required to make that information available to you. Because, and we can talk about regulatory complexity, there is nothing in HIPAA or 42 CFR, assuming there's no substance use issue related to that psychiatric encounter with the psychiatrist and the medications you were talking about, that there's nothing in HIPAA that says that they're not allowed to share that information. They absolutely are allowed to share that information. That's not a psychotherapy note, for example. So there's all that complexity there. They had the choice of saying, no, I'm not going to share that. Information blocking says, no, you don't have that choice, actually. You have to share the information unless it falls under one of the exceptions that we have, like a patient asked you not to share it, or there's a security issue, or you think it's going to cause harm to the patient or whatever. So that's like an explicit example of where you, as a provider practicing at that time, would see a benefit. You'd be like, great, that tells them they have to do that. I don't have to argue with them anymore or have big summit meetings with them. But I will also say, there have certainly been providers who have been concerned about certain details of it. I mean, overall, I think most of the provider community has been strongly supportive of the overall objective and the mission. But there have been certainly have been providers who have been concerned about certain specific aspects of it, like, for example, the requirement that's an implication of the information blocking regulations that lab results, for example, and diagnostic results be available to patients as soon as they are available to the provider. Which I think in every other walk of life, right, we've seen transparency be more and more a part of everything we do, right, with your financial information and, with Uber Eats and everything else you can do. So now that's coming to healthcare, and that's one aspect of the information blocking provisions that says, well, everyone has an expectation to be able to get the information that they paid for, and that they may want to be able to use however they want to use it as soon as it's available. There have certainly been providers who have had concerns about that. To say, well, wait a minute, that's not something that, is a part of our culture. There may be patients who actually are, have a degree of anxiety or harm, perhaps emotional harm, if they, get those results without a conversation with providers. Those are totally valid and legitimate concerns. We see those as kind of transition issues that all of us need to adjust and adapt to this new world and figure out the mechanisms for being able to have, both immediate access to those results for those patients who want them, and there are a lot of patients who want the results right away, and the ability for patients to say, I'd rather not see those results until I have a chance to talk to my doctor. And in this world, we have the opportunity for both. And so that's, I think, the transition that all of us has to go through. But we've certainly, heard that feedback from providers, and we take it very seriously. We know that that's founded in, real concern that those providers have for, for their patients.
That was also a little conversation I had with my old colleagues about, if a patient gets their lab result and it's abnormal in a certain way, how do you get the explanation to them? Because it may not be abnormal for them. It's an abnormal test, but for that, it may be very good for them.
Yep.
But you're exactly right. I think having that information out there, I mean, right now in this world where I live, I get my results before my doctor gets them.
Yep, I do too.
And that it's just the way it should work. I agree. That's
my provider has been great at, they've actually, and I think this is a part of the transition and the adaptation we have to make. My provider, for example, when they order labs, I immediately get a message in the portal that says, we have ordered labs for you. You are going to receive these before your provider has a chance to talk to you. If you don't want to look at them, don't look at them. And your provider will call you. Within 72 hours, your provider will call you. You have the choice. Don't go into the portal and look at them. So I think that we can all, and I know the technology vendors are working on other things, and we are working both with providers as well as EHR vendors to help to facilitate conversations with both of them to say, how can the technology make it easier for a provider to be able to, help through their EHR accommodate a patient's desires. So, for example, to be able to say, this patient has asked me to delay the results. So rather than telling them, don't look at the portal, is there a way that I can, as a part of the order, check a box that says, patient has requested that I delay release for 72 hours. With information blocking, that would be totally appropriate. And that's totally fine, as long as you have that conversation with the patient. And now technology vendors are starting to incorporate that in their technology. So that's why I say some of it's transition issues that we appreciate. Not all EHRs can do that today, but we anticipate that, more and more of those capabilities will come into play.
Let's talk a little bit about enforcement and about what some of the penalties are if you decide, for whatever reason, you're not going to play. I'm sorry, I'm keeping my information private.
Yep. Yeah. So as much as we appreciate the 21st Century Cures Act and what it was trying to do and the congressional backing for everything we're trying to do, I will say that that the 21st Century Cures Act also handed us a very complex set of things to implement as it relates to enforcement. And so, so what it did is it gave ONC the authority to create the policy essentially for information blocking. So to say, what is information blocking? How is that defined operationally? And what might be the exclusions for someone who decides, as you said, I'm not going to share the information. And that, the way the 21st Century Cures Act is frame this is they kind of change the paradigm to say, we're going to approach this with the assumption that all data should flow. And you need to have an exclusion or exception for why you wouldn't share the information, right? Which kind of puts HIPAA on its head in a way, right? Because HIPAA says you're permitted to share information, but it's up to you to decide whether to share it. 21st Century Cures Act literally says, no, you should be sharing the information unless you have a good reason not to. And those are those exceptions. And so that's what it said. ONC, you create the operational definition for that, and you define those exceptions. But as it regards enforcement, they said the Office of Inspector General, our sister agency in HHS, is responsible for the actual enforcement, which means they're the ones who will look at complaints. Oh, and it also said that ONC will receive the complaints. So we receive complaints. And I can talk about that in a second. And then it said OIG, though, will be responsible for reviewing those complaints, deciding which ones to investigate, and then deciding who is in violation of that and imposing penalties. So that's one complexity already, right? You have a different agency that is doing the policy from a different agency that's actually doing the enforcement. Second complexity is with the penalties. They said for health technology vendors like EHR vendors and for health information networks, they can have penalties of up to $1 million per incident if up to the OIG, right? And that's a big penalty, right? That's way bigger than HIPAA penalties, for example. So that's real, and not that HIPAA penalties aren't real, but it's a lot of money, and it's a pretty severe penalty, or it could be. But they gave new authority to the Office of the Inspector General for doing that. But added wrinkle, added complexity, is they said providers are going to have a different type of penalty. Providers will have what they called appropriate disincentives. And they said appropriate disincentives will be, we're not going to define that. We're going to ask the Secretary of Health and Human Services to define what appropriate disincentives are. And we're also going to say that the Secretary of Health and Human Services is only allowed to use existing authorities to define those appropriate disincentives, right? So they gave new authority to the Office of Inspector General to impose fines of up to $1 million each on technology developers and networks. But for providers, they said, we're not going to define that. Secretary defines that. And oh, by the way, you can't do it with any new authority. You have to use the existing programs and the existing authorities you have. That makes it really complicated because now you're placing it in the hands of the Secretary's office. It doesn't give it to an agency like to ONC or FDA. So the Secretary has to decide, well, which agency is going to do this? What's an appropriate disincentive? And just from a legal statutory perspective, where do I have the authority to impose that penalty? Because, the Office of General Counsel, can come in and say, I understand you want to do it here, but the statute doesn't allow us to do it within, that particular statute, whatever it is. So that's a lot of the complexity. So we kind of came in, not a whole lot had been done on that. We have, been doing a lot of work, on defining appropriate disincentives, on, working on, sort of creating the policy framework for that. I don't have any timelines to share on that, but I can assure you of a couple of things. One is, we will absolutely have enforcement for providers, and we're working really hard on it. And we are, and that's the second thing, is that we're working really, really hard on it. And really, what is the reason for the delay is just the complexity of it.
Let's talk a little bit then about that middle piece. We talked about providers, but now I just got back from health, as probably you were there too.
Yeah,
there was a plethora of what I call data middlemen, aggregators, massagers, all the things you could do with medical health records and data. It's interesting to see how many of them there are, but it was also interesting to see how are they going to fit in, because there's QHINs, and a lot of these are QHINs, but are they networks? Are they data aggregators? What's their responsibility in the middle of all of this to get the record from A to B?
Yeah. It's a great question. It's a really complex and increasingly complex ecosystem that we have here. And so just to, unbundle that a little bit. So under TEFCA, there's this idea of QHINs, as you've noted, Qualified Health Information Networks. There aren't any that have been designated yet, but we anticipate in early 2023 announcing the first ones that have gone through the approval process to be approved and who have agreed to the terms and conditions and the technical requirements to become a QHIN. We expect to announce that the first group that have come through in early 2023. And then we expect them to implement in 2023. So there will be these qualified networks that will have the responsibility and the opportunity to be able to, exchange information with other parties over TEFCA. And then as you point out, so they could be one form of data middlemen, as and some of them may aggregate information and may, sort of store information. Others may just be brokers, right? They actually don't even look at the information. They literally are like the old phone switchboards, right? They get the call, they see that it's supposed to go there. It's like, here, I got the message. I see it needs to go to Dr. Anders. I'm going to send it to Dr. Anders. I have no idea what's in it. I'm like the US Post Office. I just, I'm looking at the address and sending it, where it needs to go. So there's a whole variety of those kind of middlemen kind of services. But to your point, there are, increasingly data aggregators performing value-added functions. In almost all cases, I would argue they're performing value-added functions, which is to say they take data that is really messy, they curate it, they normalize it, and then they do an analysis on it on behalf of those parties that they're contracted with. What the 21st Century Cures Act opens up is the opportunity for them to work for, they've already been working for providers in many, many cases. So, I used to work for a company that was a population health management vendor, and we had, nationwide provider customers and payer customers who would send us their data and ask us to normalize that data, make it ready for analysis, make it ready for clinical quality measurement, for example, for population health management, because they themselves couldn't do it. Then someone has to do the work. They just decided to outsource it. And that all was within HIPAA. Business associate agreement, privacy requirements were all there. They weren't allowed to do anything with the information except as HIPAA allows. Increasingly, patients are being offered the opportunity by a lot of these aggregators or a lot of these companies to say, hey, we can provide you with the opportunity of you get your data and you make it available to us, or we'll offer you the technology for you to be able to access your information and then do certain things, that you want us to be able to do. I think one of the challenges that we face as a society is that once information passes outside of HIPAA, it becomes the individual's responsibility, almost their complete responsibility, to control or figure out what's happening with their data and take responsibility for what's happening with that data. And that's a big challenge because most people, don't appreciate what the boundaries of HIPAA are, unfortunately, right? So a lot of people think that, well, it's medical record data, so it must be protected by HIPAA. And they don't realize, no, it's only protected by HIPAA if Dr. J. Anders is controlling that data. But the minute that you, the individual, have the data in your hands, now it's not protected by HIPAA anymore. And so when you, download that app in the same way that, you download Open Table and we all click through, click, and we don't think about it because, I'm not really revealing anything except my phone number and my email address. So, we don't worry about it. But if you do that same thing with a healthcare app and you say, click, and the healthcare app says in it, in its privacy statement, we can take your data and do whatever we want with it. If you clicked OK on that, and all of a sudden you don't realize that you have given them the chance, the permission to sell your identified data in whatever way they want, for example. So I think that's one of the real challenges that we have as a society is to, kind of educate people on that responsibility that they are now taking into their hands. We are betting on there being a ton of value that will be available to patients through the access to their information. So, imagine, for example, that, you develop a whole ecosystem of services to be able to help diabetic patients better manage their diabetes, for example, by bringing in information from other things, by bringing in expertise and services, but they need that medical record information, right? There are many, many, many legitimate, value-added services that can be provided directly to patients as consumers to help them take advantage of their medical record information to do better things than they're able to today. Unfortunately, there are many, players who aren't the best actors in the world who will take advantage of that situation and use that information in ways that the patient didn't anticipate, and it's a surprise to them.
Let's touch on that for just a minute.
Yep.
Because in the industry today, you can see major corporations, CVS, Walmart, they're starting up and buying practices. They're getting patients. They're setting up clinics. Being in this world, you can see where the information that they will glean from patients can be used in a lot of other ways. So I'd like your comment on that, because that's, if you're the drug company who supplies all the medications and you've got a primary care practice, That's all back in the old days, that was called annulment. You couldn't do that. You had to stay away from that. So what's your thoughts on that?
Yeah, well, so the laws haven't changed on that. And certainly from a provider, from a patient and provider perspective, anyone who, if you're a provider, and you're engaged in HIPAA transactions or electronic transactions, you are covered by HIPAA. So the fact that you may be a retail entity, let's say, but you now have also got providers. Well, those providers still live under HIPAA, right? So they have to create the firewalls within their organization to say, HIPAA says you're not allowed to share, you're only allowed to share the information with other HIPAA regulated entities for treatment, payment, and operations if it's identified without consent of the patient. You're not allowed to use that information for marketing. You're not allowed to use that information in a wide variety of ways. You're only allowed to make that information available outside the boundaries of the HIPAA regulated entity, unless it's de-identified in the ways that HIPAA prescribes, which is true for providers today. Those rules still apply. So just because you're a corporate entity, that part of your entity that is, HIPAA regulated is still HIPAA regulated. You don't have any special permission to say, oh, I've got this retail business on the side, I don't need to follow HIPAA. It's like, no, that part of your organization still needs to follow HIPAA. And what we've seen, I will say, those organizations have proven themselves to be, I think, responsible stewards. I mean, I'm not, giving them any additional blessing or anything. I'm just saying that, that they act as providers, as we've seen in the market, just as other providers do.
Let's finish up with what we kind of started with, meaning I would call data responsibility on the provider side. This is not a new concept. We've had this for a very long time. Yep. In a clinic with a unified medical record, you're responsible for what's in that medical record, even though you may not have provided it. You may have to look for it, you have to find it, whatever. The thing I was talking about with my old colleagues was the fact that, say there is an abnormal mammography result that gets broadcast to me, and I don't see it for whatever reason. It's not there. And now I'm taking over the care of this patient. Patients sometimes don't realize that they had that, so that there's delays and all that. So there is a responsibility. So comment a little bit on that, on how we're going to migrate through, and it's going to be a lot of data. These medical records that are being transmitted are huge. So give me a little comment on that, how that you feel about that and provider responsibility.
Yeah, I think it's a totally valid and understandable question, and I would say just give a little anecdote from back when I first was gotten involved in health IT. So I ran a company called the Massachusetts Health Collaborative, where we were implementing electronic health records across in 3 communities in Massachusetts. So 600 providers, community providers, we were implementing electronic health records through funding that was provided by Blue Cross Blue Shield. And that was greenfield. So that was literally paper-based providers who we were implementing electronic health records, right? This is back in 2005, right? So whole different world, right? Completely different world. And I remember being with one provider who we were, standing in front of her file cabinet, which was an open file cabinet, like you always say in the pictures, right behind the reception desk, all those manila folders, and there was the whole thing going up and down. And, she was just looking up at them, and she said, every day I walk by all these folders, thousands of folders, and I think, what did we miss? Where is it? It is somewhere, right? She's like, I know it's not an if, it's where is it? I know there is something I've missed. There is some mammogram that came in that our staff put away in this file, never to be seen again until that patient has a bad experience, and then they come back and we find it. So I guess I just say that because this is not a new problem. I appreciate that it is different in scale for sure, right? And all of a sudden you're getting way more records, and some of them kind of come in a little bit like it feels like the back door, right? It's like, well, at least there was someone who had to take it off the fax or who had to open up the envelope and did it, their eyeballs were laid on it. But now I've got this electronic medical record where thousands of records are coming in the back door, and no one, is managing the, the doing the triage or monitoring the door to make sure that everything is looked at. I think that's a very fair and legitimate point. I guess I would just say, a few things, that the questions of responsibility are no different than existed in the paper world, for sure. There was a big problem in the paper world. There is that same, issue today about having to place responsibility. I will say that, electronic systems offer some advantages, though, and some benefits. First off, they have a much better ability, and that we need to get, it needs to get better and better and better, and the technology needs to get better and better and better, and the quality of data needs to get better and better and better to be able to do the kind of search and screening and filtering, to be able to identify those things. And I think the technology is getting better at being able to do that, to pick those things out, and to provide some traceability and auditability, right? To be able to say that you can say with greater assurance in an electronic medical record, for example, here is what was actually looked at. Things came in, but here is what was actually looked at, versus, in a paper record, it's like, it was in that file. And it's really hard for you to say, oh, well, I didn't see it. Because it's in the file, and so we assume that that you saw it. And I'm not saying I'm not a lawyer, I'm not an expert in malpractice or anything like that, but I'm just pointing out that the benefits of being able to have more sophisticated search capabilities that will get better and better over time, and the ability to have better auditability over one's actions, provides additional information that can hopefully sort of help and compensate somewhat for what I totally appreciate is the concern about information coming in the back door. Because I remember, when we were implementing these electronic health records, and we turned on a lab interface, and all the labs started coming in, right? And I was literally sitting there, because this was new, right, for all of us. So lab interface, we went through the testing, go live, and so I made sure I showed up at that first practice we were implementing to see it, to actually see the lab interface. And the lab started coming in, and his response was, "Stop it! Stop it! turn it off! How do I turn the faucet off? What is all of this?" And I was like, "What is all of this, doctor? These are the labs you ordered. They're the same labs you ordered. They're just coming in through the interface." But that's different, because with interoperability, you're getting a whole bunch of stuff that you didn't order, right? So I appreciate that the scope of it, is broader, for sure. I think that our workflows and our technologies are certainly have to adjust. And there are, technology offers the way to, I think, offer, sort of a compensatory better abilities to work out, to make our way through those records to the betterment of all of us.
So I'm going to finish up with the question I always ask. If there's one thing that you could change in the scope of what you do, in healthcare IT, what would it be? It would happen.
It would happen overnight.
Okay.
I guess. Yeah. No, I think the one thing, if I was going to point to a single thing, I think it would be that we, figure out the right business model to allow, payment for value-based purchasing, whatever it is we call it. And when we're making steady progress toward that, right? More and more and more. But in my experience, being able to compensate people for better health and providing better health to their patients then makes all of this stuff related to health IT an investment that they make, and not just a part of overhead. Right now, like if you're in a fee-for-service world, health IT is just overhead, right? It doesn't really change the way you get paid. It doesn't change the way maybe it offers some efficiencies, but at the end of the day, if the business drivers aren't completely aligned with that investment, it just becomes a part of overhead, and it just feels like, why am I doing this? Or I'm doing it for the health insurer, or I'm doing it because the government wants me to do it, but I'm not doing it because it's actually a part of the way that I get paid, and the way I get compensated, and the way I get fulfillment. But we've seen that the minute that providers participate in meaningful value-based purchasing, where they're incented to just say, think about your patient, think about what's in the best interest of your patient, and do the right set of things, that's when they immediately say, I need all this other information. I need all that claims data to know where the patient went. I need that interoperability. And they're not seeing all those records coming in as a liability. They're seeing all those records coming in as the opportunity to provide better care to their patients, because they have a better picture of their patients. So if I was going to be able to do one thing, I'd want to be able to say, everyone is now on that type of contract and getting paid in that way, so that they themselves can then make the best decisions they want to be able to make on behalf of their patients, and see all of this as an investment toward that better future.
Micky, thank you so much for being on the program today. It's been a pleasure and a lot of really good information for listeners. Again, thank you so much.
Thank you, Jay. Always enjoy talking to you.
That's all for today. Thanks for listening to Tell Me Where It Hurts. Tune in to Healthcare Now Radio and Podcast Network each month for the latest episode. To learn more about Medicomp systems, visit our website at www.medicomp.com. You can also follow us on Twitter at MedicompSys or myself at MedicompDoc, or check out the show notes for links. See you next time.